Hello everyone, in this video we will see how drugs which act on RAS system, that is renin angiotensin aldosterone system, act, what is their mechanism of action, what is the indications in which it is used, and what are its side effects. So let us see. First of all, to understand this RAS drugs, we need to understand the renin angiotensin aldosterone system. So here is a flowchart showing that we have angiotensinogen, which is a alpha-2 globulin which is released from liver. Now this angiotensinogen is converted by renin enzyme. Renin is an enzyme which is released from JG cells of kidney. It is converted into angiotensin 1. Angiotensin 1 is a decapeptide. Decapeptide means it has 10 amino acids. Angiotensin 1 is converted by angiotensin converting enzyme into angiotensin 2. Okay, so let me magnify it a little bit. First we'll focus here. So angiotensin 2 forms from this angiotensin converting enzyme. And where is this angiotensin converting enzyme present? It is present in the blood vessel. So if this is the blood vessel, here these are the endothelial cells lining the blood vessels. So on these blood vessels we have this enzyme. So it's a transmembrane enzyme which is attached on the apical membrane of these endothelial cells, and whatever angiotensin passes through these blood vessels which are present in the lungs, pulmonary blood vessels, this angiotensin 1 is converted to angiotensin 2. Now, important point to remember that apart from this ACE pathway, we have non-ACE pathway as well. That means there are certain other enzymes like cathepsin, kinase, especially in heart and kidney, where this angiotensin 1 is converted to angiotensin 2 by these different enzymes. Okay, so this is non-ACE pathway. Generally, we focus on ACE pathway only. Fine. So angiotensin 2 has a half-life of only 1 minute, but within this 1 minute, it does a varied lot of actions that we will shortly see. Now this angiotensin 2 is converted to angiotensin 3, and you see angiotensin 2 is an octapeptide. That means it is having 8 amino acids and it is written as 1 to 8. Now this angiotensin 2 is converted to angiotensin 3, which is a heptapeptide, that is it is having 7 amino acids, and angiotensin 3 is in turn converted to angiotensin 4. So there is a series of reactions which is occurring. Among this, angiotensin 2 is the active form. Okay, angiotensin 3 also is active. It has the activity similar to angiotensin 2 in one aspect, that is the release of the aldosterone. For other aspects, it is less potent. Most potent always is angiotensin 2. Now, you see here, focus here. I told you one thing to remember, that angiotensin 1 is converted to angiotensin 2 by two pathways. Main is the ACE pathways, but there is another pathway as well, alternate pathway, that is a non-ACE pathway. Now, angiotensin 1 can be converted to another angiotensin, that is angiotensin 1 to 7, which is formed by the action of angiotensin and converting enzyme 2. Okay, angiotensin 1 is acted upon by ACE2 and this angiotensin 1 to 7 is formed. Now again, what is the importance that we will see when we see that what are the drugs which are blocking this angiotensin converting enzyme. Okay, so for now you just remember that this angiotensin 1 to 7 is formed, and the actions of this angiotensin 1 to 7 plus the angiotensin 4 which is formed by the main pathway, the actions of these are opposite to that of angiotensin 2. Yes, opposite actions. Okay. So what are the actions of this angiotensin 2? The actions of angiotensin 2 are varied. Ultimately, the main action is to increase the blood pressure. We will see that all these effects happen such that ultimately the blood pressure increases. Okay. So first is vasoconstriction. We'll come to heart later. First is vasoconstriction, and vessels on which it acts is venules and arterioles. Both it causes a constriction. When there is constriction of the arterioles, there is increase in the total peripheral resistance. Arterioles are the main resistance vessels. So whenever the resistance vessels of the body constrict, there is increase in the total peripheral resistance. And since total peripheral resistance is the determinant of blood pressure, when there is increase in the total peripheral resistance, there is increase in the blood pressure. Okay, then venules also constrict. Venules constrict, so this leads to increase in the venous return to the heart. When there is increase in the venous return to the heart, there is increase in the force of contraction of the heart, which ultimately increases the cardiac output, and hence there is increase in the blood pressure. Fine. So both are increasing. There is increase in the preload as well as there is increase in the afterload. Afterload is by total peripheral resistance. Then angiotensin 2 also causes thirst mechanism. There is perception of more thirst, so that the person drinks more water, and there is increase in the aldosterone release. Main function of aldosterone, it acts on the nephrons, it causes the reabsorption of the sodium ions and causes the secretion of the potassium ions. So when there is increase in sodium reabsorption, there is increase in the blood volume, right? Because water also comes along with the sodium, and thirst also the person is drinking, that is going to increase the blood volume. And when blood volume increases, again the venous return is going to increase, there will be increase in the blood pressure. Okay, so you see, vasoconstriction is the one which is fast acting, immediately it will act, but it will take some time for aldosterone to release, and that's why this change in volume, it is going to take little bit more time. Then it itself acts on the nephron in the proximal tubule, it acts and it increases the activity of sodium hydrogen exchanger in the proximal convoluted tubule. So this causes again more sodium reabsorption and hydrogen secretion. Plus there is also increase in the bicarbonate reabsorption. Okay. Then it also increases the central sympathetic flow. So there is more sympathetic activity, more adrenaline release from the adrenal medulla, increase in norepinephrine release from the sympathetic system, and decrease in the uptake of the neurotransmitter which is released. Fine. So whatever is being released is staying there longer. So ultimately this epinephrine which is being released, that is also going to act on the vessels, that is also going to cause vasoconstriction, and that is again going to lead to increase in blood pressure. Understanding? So these are the various mechanisms by which the angiotensin 2 acts and increases the blood pressure. Now here is one thing which I have left, that what is its action on kidney arterioles. See, systemic arterioles all are constricted, but in kidney there are two different arterioles are there, that is the afferent arteriole and efferent arteriole. So this angiotensin 2 acts much better on the efferent arteriole, so there is more vasoconstriction of the efferent arteriole. Okay, vasoconstriction. So what will happen because of this? See, when we talk about the glomerulus, say suppose this is the nephron, right? And here we have the glomerulus. Okay. So how is the structure? Here is the afferent arteriole and this is the efferent arteriole, and these are the capillaries. Now we are telling that angiotensin 2 acts more on the efferent arteriole, so that means vasoconstriction will be more in the efferent arteriole. So since entire chain is affected, that means in series, the blood vessels are in series, right? So ultimately the resistance is going to increase. Resistance is going to increase and renal blood flow is going to decrease. Whenever the resistance increases, blood flow decreases. Flow is equal to delta P by R. R increases, so renal blood flow decreases. However, there is differential effect on GFR, glomerular filtration rate. So what we see that this efferent arteriole constriction increases the hydrostatic pressure in this glomerular capillaries. How? See, it is blocking the outgoing. Incoming is there, but outgoing is blocked much more. Okay, yeah, incoming little bit also decreased because renal blood flow is decreasing, but compared to that, outgoing is blocked much more. So increase in hydrostatic pressure in the glomerular capillaries, and this increases the filtration, because hydrostatic pressure is the push force, it increases the filtration. So GFR increases in kidneys. Okay, renal blood flow decreases but GFR increases, and this effect is especially seen in conditions in which there is decrease in renal blood flow. So this is important to understand, because later we will see one condition in which ACE inhibitors are contraindicated. So we should understand how this angiotensin 2 is acting. Okay. Coming back to actions of angiotensin 2, yeah, kidney, it is causing efferent arteriole vasoconstriction, and that is why it is increasing GFR. okay, but decreasing renal blood flow. Now, apart from these systemic actions, that is when angiotensin 2 is formed by the action of the ACE present on the pulmonary blood vessels. But there are certain local actions as well in the heart and blood vessels, which are very, very, very important. Okay. So, what happens that nowadays there is another theory which has come that angiotensin 2 is produced locally as well in heart and blood vessels. So, in the heart, it causes hyperplasia, hypertrophy, and increase in intracellular matrix deposition, that is increase in the collagen deposition. It is causing fibrosis. Okay, so there is increase in the number of the cells and there is fibrosis as well. Collagen deposition is occurring. Same thing is happening in the blood vessels as well. There is increase in the wall thickness and this is going to lead to increase in the thickness of the wall and intimal thickness also. Intima is the inner layer of the blood vessel, that also thickens. So that is the direct action. Indirectly also it increases these effects. How? See, we are telling that it is increasing the blood pressure, it is increasing the afterload, and because of this the heart has to keep pumping more against this huge resistance. Afterload is the resistance offered to the heart. Okay, so now heart has to pump against this resistance, so that also causes hyperplasia, hypertrophy and ICM deposition. And the blood vessel wall also thickens. Why? Because in the blood vessels there is more pressure, so that initiates some remodeling changes in the blood vessels, so that there is increase in the wall thickness. Fine. So these are the various actions of the angiotensin 2, and we have seen here that angiotensin 1 to 7 and angiotensin 4 have actions opposite to that of angiotensin 2. So what are these actions? Actually, these angiotensin act as vasodilator. They are anti-proliferative. Okay, so they won't cause hyperplasia, they will oppose this. They are anti-proliferative and they promote apoptosis, pro-apoptotic. Okay. Now, how is this renin released from the kidney? Because renin is the main enzyme from which angiotensin 1 is being produced and then angiotensin 2 is forming. So, what are the stimulus for renin release? So, there are three main stimuli for renin release. One is increased sympathetic activity, which acts on the beta 1 receptors present on the JG cells of the kidney. So, these juxtaglomerular cells, they are present on the afferent arteriole in the kidney. This norepinephrine acts on the beta 1 receptors present on the JG cells. Mechanism of action is it increases the intracellular CMP, increasing the formation of prorenin from which renin is formed. So both are being formed and released. Okay. Then next mechanism is decrease in the renal blood flow. The decrease in the renal blood flow itself causes increase in the renin release. So afferent arteriole is here, no? We have seen the diagram before. This is the afferent arteriole. Because the renal blood flow is less, here the stretch is less in the afferent arteriole. So here certain ion channels are there, stretch sensitive ion channels, which ultimately lead to increase in the production of prostaglandin E2 and nitric oxide. Okay, so main mechanism is that there is formation of prostaglandin E2 and nitric oxide, because of which there is increase in the release of the renin. Then third mechanism is macula densa, that is the tubuloglomerular feedback. Okay, how this is acting, let us see. In tubuloglomerular feedback, what happens that when there is decrease in the renal blood flow, this causes decrease in the glomerular filtration rate, because decreased renal blood flow leads to decrease in the hydrostatic pressure in the glomerular capillaries. So this decreases the GFR. This decreased GFR ultimately leads to decreased sodium delivery to the macula densa cells. Where are these macula densa cells located? So this is the nephron, okay, and it goes like that. The DCT part, it goes like that, okay. So ascending limb of loop of Henle, and this is the distal convoluted tubule. Here macula densa cells are located. So when there is decrease in the GFR, the sodium which goes to this macula densa cells, it is less. So that is what, there is decreased sodium delivery to the macula densa. And when this happens, there is release of certain transmitters. Actually, there is a decrease in release of adenosine, okay, and there is increased production of prostaglandin I2 and nitric oxide. So that is what we are seeing here. Prostaglandin I2 and nitric oxide form, which cause the release of renin from JG cells. So there are three mechanisms. One, increased sympathetic activity, decrease in renal blood flow, and tubuloglomerular feedback causing decreased NaCl delivery to macula densa. Now, one fundamental thing you note here, that all this will be activated when there is decrease in the blood pressure. How? See, decrease in blood pressure activates sympathetic activity by the baroreflex. Decrease in blood pressure also decreases the renal blood flow. And when renal blood flow decreases, there is decrease in the GFR, which causes decreased sodium delivery. So, decrease in the blood pressure activates all these three, causes release of the renin. Okay. So, why I am telling you this? Because angiotensin 2 acts in a feedback manner and controls the release of renin. How? See, angiotensin 2, I told you that it is causing increase in the blood pressure, right? So, ultimately, angiotensin 2 causes increase in the blood pressure. Increase in the blood pressure is going to decrease all these mechanisms, causing decrease in the renin release. So, whenever angiotensin 2 formation increases, there is increase in the blood pressure. Let us see like that there is ACE, right? So, renin is acting here, forming angiotensin 1. Okay, so angiotensin 2 formation increases blood pressure. This in turn affects all the mechanisms for renin release, causing decrease in the release of the renin. This is known as long loop negative feedback. Long loop negative feedback. Then we have other mechanism also. Actually, angiotensin 2, to carry out its action, it acts on two types of receptors. We have AT1 receptor, angiotensin 1 receptor, and AT2 receptor, angiotensin 2 receptor. AT1 receptor and AT2 receptor both are G protein coupled receptor, but the mechanism is little bit different. AT1 basically is of GQ type, that is, it acts via phospholipase C pathway. What happens in phospholipase C pathway? Phospholipase C is an enzyme which is present on the membrane. Okay, so this is the membrane. Here there will be AT1 receptor. Angiotensin 2 will come and bind on this receptor. So this is a G protein coupled receptor. That means like any other G protein, it has alpha, beta and gamma units. But this alpha is of GQ type. So it activates phospholipase C enzyme. Okay, so it dissociates and activates phospholipase C enzyme. Phospholipase C acts on the membrane lipid. So here are all membrane is made up of lipids, right? It acts on this membrane lipid, that is phosphatidyl inositol phosphate. Okay, so PIP2, phosphatidyl inositol diphosphate, and causes the formation of IP3 and DAG. Okay, so this is the mechanism of action of angiotensin 2, phospholipase C, IP3, DAG. IP3 ultimately will cause the release of calcium from the sarcoplasmic reticulum, and diacylglycerol will activate protein kinase C, such that there is a phosphorylation of the various proteins and the action of angiotensin 2 is brought about. This calcium release will cause vasoconstriction, increase in the calcium. Okay, smooth muscle contraction it will cause. So that is one mechanism. Then some organs have GI type of AT1 receptor, that is kidney. Okay, so when this GI type of AT1 receptor is activated in the kidney, this receptor is there is decrease in the formation of CAMP, because this GI type, actually again if you see, we have a G stimulatory, G inhibitory and GQ type of GPCRs. GQ, I told you that it is activating phospholipase C. G stimulatory activates adenyl cyclase enzyme. So this adenyl cyclase enzyme ultimately leads to formation of CMP. But I told you that AT1 receptor in the kidney is GI type, not GS type. So this leads to decrease in activation of adenyl cyclase enzyme. So whatever activate enzyme is there, now it will not be activated, it will be inhibited, and there will be decrease in the formation of CMP. Okay, so what is the significance? See, we have seen here in renin that this sympathetic activity by acting on the beta 1 receptors, it causes increased CMP. So this angiotensin 2, by decreasing CMP, it is going to decrease renin release. So this is known as short loop negative feedback. Long loop negative feedback, that is by its actions to increase the blood pressure, it is decreasing renin activity. Short loop negative feedback, just by its action on the AT1 receptors in the kidney, it is decreasing CMP and causing decrease in the renin release. Okay. Now, this is the fundamental. Once we have understood this, it is very easy to understand our drugs. Okay. So, let us see what are the drugs. So, first component is that what are the drugs which affect the renin release, that we are going to see. So, once you have understood this, simply you see that because the renin release is dependent on sympathetic activity, macula densa, NaCl delivery and renal blood flow, any drug which decreases the sympathetic activity or affects the sympathetic activity, that is going to affect the renin release. So, we have vasodilators. Vasodilators cause vasodilation. Yes, arterial vasodilation will occur. There will be decrease in the resistance. There is decrease in the total peripheral resistance, thus causing decrease in the blood pressure. And we have seen when there is decrease in the blood pressure, it affects the sympathetic activity by baroreflex. So, decrease in blood pressure increases the sympathetic activity, and this increased sympathetic activity increases renin. So, vasodilators increase renin secretion. Saw the mechanism, right? Diuretics, they decrease the blood volume. They are causing the water loss from the kidneys. So, blood volume is decreasing, blood pressure is decreasing. So, this also increases the sympathetic activity by baroreflex. So, there is increase in the renin. Understanding? So, that is the mechanism that vasodilators and diuretics will cause increase in the renin release. Then, what are the other drugs? We have phosphodiesterase inhibitors. Phosphodiesterase inhibitors. What is the action of phosphodiesterase? Phosphodiesterase actually degrades this CMP. Okay. So, here phosphodiesterase acts and decreases the concentration of CMP. It converts it into 5-AMP. There is degradation of CMP, and since increased CMP is releasing renin, if we give phosphodiesterase inhibitors which block this phosphodiesterase enzyme, what will happen? CMP will not be degraded. If it is not degraded, there will be increase in the CMP and hence there will be increase in the renin release, right? So that is the third drug. Fourth, COX-2 inhibitors. What do COX-2 inhibitors do? COX-2 inhibitors decrease the production of prostaglandins. Okay. So, there will be decrease in the production of prostaglandin E2 which stimulates renin. So, COX-2 inhibitors will decrease the renin release. Okay. So, this happens with NSAIDs. NSAIDs, non-steroidal anti-inflammatory drugs which are COX-2 inhibitors. And this is important because the effect of these NSAIDs on the renin release affects the function of the body, and it directly causes decrease in the release of the renal blood flow as well, because prostaglandin E2 is one stimulus for vasodilation as well. So, because of decrease in the prostaglandin E2 production, there is decrease in the renal blood flow and kidney damage can occur. Then, what is the next drug? We have renin inhibitors. Direct renin inhibitors are there which inhibit the action of the renin. Then we have the ACE inhibitors which act on the ACE enzyme and inhibit it. Then we have the angiotensin receptor blockers. Angiotensin receptor blockers, they basically inhibit this AT1 receptor. They block this AT1 receptor so that angiotensin 2 is not able to act. So what will be the effect of these drugs, that is the renin inhibitors, ACE inhibitors and ARB on the renin release? They are going to increase the renin release. See, they are decreasing the action of this system. Angiotensin 2 is not able to act because of ARB. Angiotensin 2 is not forming because of ACE inhibitors. Renin action is decreasing, causing decreased formation of angiotensin 1 and hence of angiotensin 2. But ultimately, because of decrease in the action of this system, there is decrease in the feedback loop and this causes increased renin release. I am talking about increased renin release. Okay. So, all these drugs affect the renin release. What are these? Vasodilators and diuretic increase renin release. Phosphodiesterase inhibitors increase renin release. COX-2 inhibitors decrease the production of prostaglandin E2 and hence decrease renin release. Then renin inhibitors, ACE inhibitors, ARB, they all increase the renin release. Okay. So actually I should write it in green. Okay. Because they are increasing the renin release. They are blocking the action of the system but increasing the renin release. Fine. Now moving on to specific drugs, that is the ACE inhibitors and ARB. First we will talk about ACE inhibitors. So what is the indications of ACE inhibitors? So ACE inhibitors, they inhibit the enzyme angiotensin converting enzyme, and because of that there is decrease in the angiotensin 2 formation. So all actions of angiotensin 2 will be lesser. It will not be able to cause vasoconstriction, no thirst, no aldosterone release, no local actions as well. So there will be decrease in blood pressure whenever we give this drug. So yes, when is it used? It is used in hypertension. Then it is used in congestive heart failure. Why it is used in congestive heart failure? Because we have seen that angiotensin 2, what it does? It causes vasoconstriction of the venules as well as the arterioles. So with this there is increase in the preload, and arteriole there is increase in the total peripheral resistance. So if this angiotensin will not form, then preload will be less, total peripheral resistance will be less. So this is good during the congestive heart failure. Why? See, in congestive heart failure, the heart either is not able to pump or there is problem in the relaxation of the heart. So in both cases actually there is decrease in the cardiac output, decrease in the blood pressure. Cardiac output is the determinant of the blood pressure. So because of this, increased sympathetic activity happens, leading to increased total peripheral resistance and increased afterload. So we are telling that heart is already not able to pump adequate cardiac output, and now you are increasing the afterload. Will it be good for the heart? Yes, see, initially when it is compensatory changes going on in the body, initially it is good to maintain the blood flow. This afterload is important because it maintains the pressure head and thus maintains the blood flow. But over time it becomes counterproductive. So this increased afterload has to be stopped, and that is done by ACE inhibitors because this angiotensin 2 formation decreases. Angiotensin 2, we have seen that it increases the sympathetic activity, increases TPR. So we have to block this. Then angiotensin 2 also causes increase in the blood volume, we have seen, causes sodium reabsorption from the kidneys because of the aldosterone release. So there is increase in the preload as well. Again, in the beginning it is good for the heart, but over a period of time it increases ventricular wall stress. So ACE inhibitors block this as well. So they control the preload and the afterload in congestive heart failure. So that is the second indication. Third, in evolving MI, myocardial infarction. Evolving MI means that is within 24 hours of attack to up to 6 weeks. When all the wall changes in myocardial infarction are taking place, that time ACE inhibitors have to be given. Now why? Again, because we have seen the local actions of the angiotensin 2. What are the actions? It causes hyperplasia, hypertrophy and fibrosis also. So what happens that especially the heart which is infarcted, the fibrosis there, it causes the dilation of the heart and affects the functioning of the heart. It will not be able to contract in a sync manner. Okay. So these changes are decreased. The harmful changes which happen during MI are decreased when we give ACE inhibitors. They block the action of angiotensin 2. Then in diabetic nephropathy and diabetic retinopathy, because ACE inhibitors have been found to decrease the proteinuria. In diabetic nephropathy. Okay, not retinopathy. Decrease proteinuria in diabetic nephropathy and also in non-diabetic renal diseases, right? Then ACE inhibitors have also shown use in other vascular complications of the diabetes, that is the retinopathy. Okay. Again, we have seen angiotensin, how it is causing the local changes in the blood vessels also, right? Intimal thickness and all. So it helps in diabetic nephropathy, diabetic retinopathy, preventing these changes. Then it is also given in scleroderma crisis. Why? Scleroderma is an autoimmune condition of the skin basically, but in scleroderma crisis, there is malignant increase in the blood pressure, malignant hypertension occurs, and during this condition, ACE inhibitors have to be given. Because simple, main function of angiotensin 2 is increasing the blood pressure. We block that, blood pressure is controlled. Okay. Now in brief, we will see what are some ACE inhibitors, what are the adverse effects and contraindications. So ACE inhibitors include captopril, which was the first drug to be used, but it is shortest acting, less potent and fast acting. And because of being very fast acting, it has a more tendency to cause postural hypotension. Then we have enalapril. Another form of this, that is enalaprilat, is available for IV use in hypertensive emergencies. Perindopril, it is longest acting. Obviously, there are certain other drugs also. I am not going to discuss that. What are its adverse effects? Very important. One is dry cough. Why dry cough? Why is it occurring? See, ACE enzyme we have seen, it converts angiotensin 1 to angiotensin 2. But it has another action as well. It is important for the degradation of bradykinin. Okay, it degrades bradykinin. So when this ACE enzyme is blocked, this bradykinin and also substance P, they are not degraded, they accumulate. And this increase in bradykinin and substance P, this causes dry cough, mainly bradykinin. That is responsible for dry cough. And also angioedema. Angioedema, it is a serious condition. So if this occurs, then immediately the person has to be given epinephrine, antihistaminics, glucocorticoids, and obviously ACE inhibitors need to be stopped. The next adverse effect is postural hypotension. I told you postural hypotension can occur especially in the initial few doses when they are giving, and especially prone in patients who are already taking diuretics. So blood volume is lesser in them, so postural hypotension may occur. Then it can cause hyperkalemia. Why hyperkalemia may occur? Because when angiotensin 2 is not available, there will be decrease in aldosterone, and function of aldosterone is increase in the sodium reabsorption and potassium secretion. Okay, so when there is decrease in aldosterone, there is decrease in the potassium secretion. This can lead to hyperkalemia, especially in patients on potassium supplements or on potassium sparing diuretics. Okay, so those are the various adverse effects. Coming to contraindications, when is it contraindicated? It is contraindicated in bilateral renal artery stenosis. So you remember we discussed that how angiotensin 2 is mainly acting on efferent arteriole, right? So here is the mechanism that it is useful in bilateral renal artery stenosis. When both sides renal arteries is stenosed, there is decrease in the renal blood flow, there is decrease in GFR, and there is increase in the renin release. Because decreased GFR, there will be decreased sodium delivery to the macula densa, causing increase in the renin release. This in turn will cause angiotensin 2 formation. Okay, angiotensin 1 formation, then angiotensin 2 will be formed, which acts on the efferent arteriole, right? And despite decrease in the renal blood pressure, it maintains the GFR. It is going to increase the GFR. That's what we discussed, that even though renal blood flow is decreasing, GFR will be maintained. But suppose you give ACE inhibitors in such people, then this protective mechanism which is there, it will not happen, and there will be decrease in the GFR, and it will precipitate acute renal failure. So ACE inhibitors are contraindicated in bilateral renal artery stenosis. They are also contraindicated in pregnancy because they are fetopathic. Okay, they cause congenital malformations. So that was about ACE inhibitors. Moving on to angiotensin receptor blockers. Angiotensin receptor blockers, what they will do? They will block the angiotensin 1 receptor. Mainly they act on angiotensin 1 receptor. So they block that angiotensin 1 receptor so that the angiotensin 2 is not able to act. So it is being formed, but it is not able to act. Okay. Now this angiotensin receptor blockers provide a more complete block of angiotensin 2 compared to ACE inhibitors. Why? Because again we have seen before that angiotensin 2 can form apart from the ACE pathway. It can form by alternate pathway as well. ACE inhibitors block this pathway, right? But angiotensin 1 then will be diverted to formation of angiotensin 2 by alternate pathway, and this angiotensin 2 will be able to act, right? ARBs are blocking here below so that angiotensin 2 formed by any pathway, its action will not occur. Okay. So this is now preferred in hypertension, better drug in hypertension, and it also doesn't cause any cough and angioedema. Why? Because bradykinin is not getting accumulated. ACE inhibitor is active, no? So bradykinin will be degraded. So no cough and angioedema as well. So preferred in hypertension. However, in myocardial infarction and CHF, still ACE inhibitors are being used, because research wise we have more data about the action of ACE inhibitors in these conditions. ARB not much explored. Okay. So what are these different angiotensin receptor blockers? We have losartan, telmisartan, eprosartan. So these end in sartan. Okay. So losartan, telmisartan, eprosartan. There are others as well. Some characteristics of these are losartan also has antiplatelet action and has some uric acid secreting action, uric action. Telmisartan is longest acting and it also has some effect in dysglycemia. Okay, so it improves the insulin resistance. Eprosartan is shortest acting, right? So those were the ACE inhibitors and the angiotensin receptor blockers. Now, before I told you that we have direct renin inhibitors as well. These direct renin inhibitors, some example are aliskiren, ramikiren, enalkiren. So they are ending in kiren. Okay. So they are also now alternative drugs which can be used for chronic hypertension or hypertension which is not responding to other therapy. So that was all about the drugs which act on renin-angiotensin system. I hope I was able to clear your concept. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.